Welcome and thank you for joining us today. My name is Dr. Paul Schroy and I co-chair the National Colorectal Cancer Roundtable's Family History and Early Onset Colorectal Cancer Task Group, along with my esteemed colleagues Dr. Dennis Anand and Dr. Thomas Weber. The purpose of today's webinar is to provide an overview of what we know and don't know about colorectal cancer screening for those at risk due to a family history. The content is based on a comprehensive review of the literature conducted by Dr. Jan Lowry in collaboration with the Family History Task Group and a number of renowned experts in the field. The results of this review were published in the journal Cancer in September in an article entitled Understanding the Contribution of Family History to Colorectal Cancer Risk and Its Clinical Implications, a State of the Science Review. Today, we'll hear from two of the lead authors to learn about their key findings, including recommendations for next steps. We will first hear from Dr. Dennis Anand from Gastroenterology of the Rockies. Dr. Anand is Professor Emeritus at the University of Colorado School of Medicine and a member of the Roundtable Steering Committee, as well as co-chair of the Family History and Early Onset Task Group. Dr. Jan Lowry will follow. Dr. Lowry is an analytics data scientist at the Catholic Health Initiatives Institute for Research and Innovation. I'd like to share a few housekeeping items, though, before we get started. We are recording today's webinar. The replay and speaker slides will be available to everyone within a few days, and we encourage you to share with your colleagues who were not able to join us today. Also, because of the large number of participants, all of you are muted on today's webinar. Having said that, we still want to ensure that you get what you need out of this session, so we encourage you to ask questions by submitting them through the webinar Q&A function. We will have time for questions after the presentations, and we'll answer as many as time permits. We will also be emailing responses to any questions we don't have time to get to. In addition, we encourage you to contact us by email with specific questions that may come up afterwards. And finally, in an effort to constantly improve our presentations, we need your input in evaluating today's webinar. To do so, we will be sending an email with a survey link. Please help us out by taking a few minutes to complete the survey and provide feedback. We take this advice very seriously. So with that, I am pleased to turn the webinar over to Dr. Anand, who will begin by providing an overview of familial risk in colorectal cancer.
Thanks, Paul. It's really a treat to actually talk about this topic. We think it's an important one. The Roundtable has made a big effort to focus not only on average risk people, but now on individuals at increased risk because of family history. So I appreciate all of you who've joined us and hope this will be helpful for you. The first question I thought we should address is, why did we really have this focus on family history? Why is it important? Well, family history is the basis for the hereditary syndromes, and this paper and this talk today, the webinar today, is not about the hereditary syndrome so much, but it's important to recognize that the use of the family history is the basis for diagnosis of the hereditary syndromes as well. But it's also an important risk factor for sporadic colorectal cancer. Family history changes screening recommendations substantially, and we'll review that. But the guidelines for the basis of screening in family, on the basis of family history, do vary substantially. We'll talk about that. And screening rates are low in individuals with a family history, particularly at the younger age of the family history spectrum. So there's good rationale for focusing on family history. Family history, as I said, is one of the risk factors for colorectal cancer, but there are many. There are demographic factors that we can't do very much about. We can't change our age or where we were born, our race, or our family history for that matter. But there are other risk factors that are modifiable, lifestyle risk factors and dietary risk factors that are listed here. In addition to that, perhaps one of the single most important risk factor for colorectal cancer is the failure to get screened. We know that screening works, and failure to get screened is an important risk factor for colorectal cancer. So I think it's worthwhile to think of it in that context. Of all of these risk factors that are listed here, only age and family history are incorporated systematically into screening recommendations. We recommend screening starting at a certain age, stopping at a certain age, and we stratify screening recommendations based upon family history. So we're going to talk a bit about both of those issues as we go along. But first, I thought I'd like to put it in a little bit of perspective. So about 70 or 75% of all colon cancers are sporadic. That is, people have a colon cancer, have no family history, a first or second degree relative with colorectal cancer or advanced adenomas. Down on the bottom there, those three little slices of the pie are the hereditary colon cancer syndromes. Together, they account for perhaps around 5% of all colorectal cancers. And then there's this big group that may be about 25% of individuals with colon cancer who have also a family history of colon cancer, where there's some familial component that we don't yet understand the specific genes involved, but we do know that the other family members are affected as well. To put this in a different way, of the entire general population, somewhere between 10 and 20% of the general population have a first-degree relative with colorectal cancer or a first-degree relative with an advanced colorectal adenoma. And so this is a huge group. This is a huge high-risk group. So it's important to pay attention and try to address this group, and that's what we're trying to do here. This is old data now, but still important data from Charles Fuchs and colleagues showing the impact of family history, both in age, on colorectal cancer risk. And this is colorectal cancer incidence as a function of age. The curve on the right shows that colon cancer incidence begins to increase substantially around age 50 and then doubles every decade until around age 80 in individuals with no family history. The important point here is to compare the curve on the left. That are individuals with either first or second degree relative with colorectal cancer. You can see that the age incidence is shifted to the left and that the risk of colon cancer in a 40-year-old that has a family history is about the same as the risk in the general population in the 50-year-old group. And this is the kind of data that has caused the recommendations to be different in individuals that have a first-degree relative with either colon cancer or an advanced adenoma. This presents the data in a graphic form. The lifetime risk of developing colorectal cancer in the United States is about 4.5 to 5%. If you have a first-degree relative with colon cancer, the bar on the left, it increases that risk about 2 to 3-fold. If you have a young first-degree relative or 2 first-degree relatives with colon cancer, that would be a parent, sibling, or child, the risk is increased 3 to 4-fold. If you have more than 2 first-degree relatives with colon cancer, the risk of developing colon cancer is remarkably high. It's almost as high as if you were born into a family with a hereditary syndrome such as Lynch syndrome. So very important stratification on the basis of family history with respect to risk. It's also important to recognize that it's not just cancer family history, it's a family history of advanced colonic adenomas. That's large or histologically advanced adenomas is associated with about a similar risk, increase in risk, as having a first-degree relative with colorectal cancer. So these are important issues, both colon cancer family history and adenoma family history. We'll talk about both of them today. Screening intensity increases as you go along the spectrum from no family history to 1 or more family members, and we'll talk about some aspects of those screening recommendations as well. So how are we doing with respect to colon cancer screening in general, and particularly in those individuals that have a family history of colon cancer? The bar shown in red here is the rate of colon cancer screening, adherence with colon cancer screening in 2005 on the left up to 2010. And you can see we're increasing the screening rates in this country pretty steadily. The 80% by 2018 effort is to accelerate that and get to a higher level yet. And you can see that in the blue line, individuals that have a first-degree relative with colon cancer in the population over those first-degree relatives who are at the screening range of over 50, we're doing a bit better. We have higher screening rates in those with a family history than those without a family history in the over 50 group. However, in individuals that have a first-degree relative with colon cancer but themselves are in the 40 to 49-year age group where screening recommendations start, for those individuals, you can see that the rates in this brown bar, or this brown line here, are substantially lower than they are in either those without or with a family history of colon cancer over the age of 50. So we have a real challenge ahead of us to try to identify these family members and be sure that we start screening earlier as the recommendations would suggest. So this is why we focus on family history. Family history of colon cancer or an advanced adenoma is common, 10 to 20% of the population. It's a huge high-risk group. It's an important risk factor that alters screening recommendations. But the screening rates at the younger age in the 40 to 50-year-old group are low in those with a family history. And so a major purpose of doing this review that Jan led was to review the current state of knowledge and identify gaps and opportunities in this area to try to improve screening in those with a family history. So with that, I'll pass it over to Jan to tell you a little bit about the study, how it was done, and what we learned.
Thank you, Dennis. So as Dennis just said, the Family History Task Group embarked on this endeavor to conduct a State of the Science review to help us understand the state of the science around family history and colorectal cancer on a number of issues in terms of the risk of unaffected family members of those that have colorectal cancer and adenomas, understanding where we are in terms of the guidelines that currently exist, the current screening rates that we know about, and including some of the barriers and facilitators to screening in these high-risk populations. What are some of the interventions that have been tried and have they worked? And we also wanted to understand what's out there in terms of the tools that providers and patients are using to collect family history to inform screening. And our ultimate goal was that the information that we gleaned through this review and from this process will help us inform research gaps and needs, how and where to prioritize efforts to improve screening in these high-risk populations, and importantly, help us identify the need for collaborations between the current members of the roundtable, but also new partners that we would need to engage in order to address some of these priorities. So we decided to conduct a comprehensive review of the literature, and we reviewed articles that were published within the past 10 years, including a few sentinel papers as appropriate. And these were articles or studies that supported six questions that we were interested in answering. What are the risks for colorectal cancer associated with a family history of colon cancer or adenomas? And as Dennis alluded to earlier, this was limited to families that did not have colon cancer in their family due to a known hereditary syndrome. So this is that larger 25% group that Dennis showed earlier at high risk due to their family history. Question 2 was, what are the existing screening recommendations for individuals with these family histories? What are the rates of adherence to screening among these individuals? And what are the predictors and barriers to screening in high-risk populations? What interventions have proven effective for improving screening rates in high-risk populations? And lastly, what types of tools are available for assessing family history to inform colorectal cancer screening? So we used the standardized protocol to develop our search strategy, our inclusion criteria, and methods for data abstraction and synthesis. In total, we identified and reviewed over 5,000 articles, again, over the past 10 years. We ended up including 76 studies that met our criteria. These were included in the review. We decided to present the results in terms of what we know based on the evidence in the literature, again, and what is not known. Where are the gaps, or where is there insufficient or inadequate evidence to support some of these questions? The findings were reviewed by an expert panel that was convened by the roundtable, and this consisted of primary care physicians, gastroenterologists, and other specialists, researchers, public health, and policy experts. And based on the results, this group came together and has come up with 8 recommendations for addressing some of the priority areas identified through the review. And Dennis and I will be talking about those a little bit later in the presentation. So for question 1, we separated these into 2 questions. The first being, what are the risks for colorectal cancer associated with a family history of cancer, colorectal cancer, versus adenomas, which will be the next slide. And so on the bottom of this graph are the various categories of family history, and you'll see that some of these are similar to the data that Dennis just presented. And the blue bars represent the risk of developing colorectal cancer relative to individuals that do not have a family history of colorectal cancer, and that's denoted by the red dotted line. And I will say for most, there was several studies that were included for this question, all of which, except for having a first degree over 70, these are pooled estimates from meta-analyses. And you'll see, as starting from the left and going and moving to the right, having at least one first degree relative with colon cancer increases risk by about a little over 2.25. The risk increases dramatically if you have more than 2 first degree relatives, or if you have a relative diagnosed under the age of 50. If one has a relative diagnosed with cancer under age 60, it's a little bit over 2, and slightly under 2 if you have a relative that's 60 or older or 70 or older. This graph depicts the risks associated with having a family history of adenomas. And I will note that there were very few studies that we could find in the literature, only 4. So most of these are estimates given from 1 or 2 studies, with the exception of the first bar, which is having 1 or more first-degree relatives with any type of adenoma, and that risk is at about 2. And again, these are relative risks, so these are relative to individuals that do not have a family history of adenomas or colon cancer. So the risk is about the same if you have 1 first-degree relative with a large or advanced adenoma, a little bit less for a relative under 60, but it's higher if you have a relative under 60 with an advanced adenoma or over 60 with an advanced adenoma. So even though we attempted to select studies that did not include families with known hereditary syndromes, we did not know to which extent there might be misclassification in these studies, which could potentially overestimate risk. We also recognize that there is a significant role of environmental factors, which we have not accounted for with these risks. But one of the important findings from this exercise was there's very few studies on adenomas. And as you can see, there's various ways in which the adenomas were defined in terms of size. Few studies, if any, have looked at risk associated with adenomas by type or location. And those would certainly be something, a gap in the research that we would propose would need to be addressed moving forward. For question 2, in terms of screening recommendations, we found that 7 organizations do provide guidelines specific to individuals at increased risk due to their family history, and these are listed here. American Cancer Society, the NCCN, the Multi-Society Task Force, the American, let's check my notes, College of Gastroenterology, and the American Society for Gastrointestinal Endoscopy, American College of Physicians, and the Institute for Clinical Systems Improvement. So we've included all 7 into the review. We found that the guidelines are consistent for individuals that have 1 first-degree relative with colorectal cancer, or adenoma should be added there, but they're variable depending if an individual has a family member that's diagnosed at 60 years or older. There's also variability in how the guidelines reference adenomas. 2 of the 7 organizations specifically state advanced adenoma, where 5 only state adenoma. And only 3 of the recommendations contain recommendations if a person has a second-degree relative that's been affected with colon cancer. So here are the recommendations for these high-risk groups. According to group, the recommended screening exam, and the age to start screening, and the interval. Then at the top row, that's bolded, again, consistent recommendations if an individual has 1 first-degree relative with colon cancer or an adenoma, and we've grouped those together here, under age 60, or more than 1 first-degree relative that's affected. The recommendation is colonoscopy, and to begin at age 40 or 5 to 10 years younger than the earliest diagnosis in the family, and to repeat colonoscopy every 5 years. You will see that if someone has a first-degree relative diagnosed at or over age 60, the recommendations do vary from recommending any modality or colonoscopy, or really no recommendations at all, with the starting age being either 40 or 50 in either every 5 or 10 years. So although we have recommendations for these high-risk groups, what we don't know is whether or not these are being utilized and by whom. We don't know. There's very few studies on provider adherence to the guidelines. Does it differ by specialty? Does it differ by patient population based on insurance status, et cetera? What are the patients being told, and do they, in fact, understand the guidelines? Given the complexity and the variability in the guidelines, how does that impact screening and the recommendations that are given to patients? There's also some discussion within the task force whether there is substantial evidence to support the recommended intervals. I think there was consensus on the age to start, given the risks that Dennis alluded to early on. The studies are still ongoing, however, to support whether the recommendation should in fact be every 5 years or every 3 years or every 10 years in some groups. In terms of screening adherence, what we found, and again, I'm just duplicating what Dennis had mentioned earlier, that the screening rates tend to be pretty low. Among first-degree relatives of individuals with colon cancer, about 50% of individuals have ever had a colonoscopy. The screening adherence is lower if we look at risk-appropriate screening, defined by age of initiation, and having screened in this population every 5 years, or at least within the past 5 years, only about 30% would be adherent. And adherence is even lower. There was one study that was able to look at adherence over time. So starting at age 40, having screening every 5 years for the next 20 years. And there was only one study, but the estimate is that it's less than 10% of the population remains adherent with these recommendations over time. The population-based estimates in the U.S. suggest that screening rates are improving, but not necessarily among persons under age 50. So that 40 to 49 age risk group is not getting screened adequately. I believe the screening rates are about 40% or less in that group. So again, what we don't know is what is adherence over time. As I mentioned earlier, a few studies have been able to examine longitudinal adherence. And adherence in the general population, the current systems that we have, it's really difficult to measure risk-appropriate screening based on the questions that we're currently asking through the National Population Health Surveys, for example, both in terms of screening and in terms of stratification based on family history. So work really needs to be done if we want to use those mechanisms to measure adherence over time in populations, that we improve those systems for collecting that information. So we also looked at predictors and barriers to colorectal cancer screening in high-risk populations, and we separated this into patient groups and provider groups. And for patients, this is based on a meta-analyses, some of the most important predictors or facilitators to screening included having a physician recommendation, having multiple affected relatives in one's family, the relationship that one had with the affected family member or the closeness of that relationship, and the social influence of family and friends. There were several other predictors, including having insurance, perceived risk of colon cancer, knowledge of your relative's diagnosis, and having discussed your family history with a provider. And although important, by virtue of magnitude, the ones listed on the screen are the ones that came across most strongly as predicting screening in this high-risk population. Important barriers that were noted in the literature, including not having symptoms, having a fear of the test or anticipated pain from having colonoscopy, and not having a doctor recommendation. And you'll note that many of these are barriers or facilitators that we would also see in average risk populations, with the exception, of course, of having affected relatives. And as a group, we see that as an opportunity, perhaps, to engage those family members, the affected individuals or the cancer survivors, in helping us move the needle on screening in these families. In terms of providers, what we learned from the literature that facilitates screening in high-risk individuals, patients, and their families are having access to messages about risk with practical rules for applying the recommendations to their high-risk populations or patients, having a communication with patients about their risk based on the family history, and having access to targeted educational messages that physicians could use in their offices. Some of the barriers noted were lack of educational resources for managing high-risk patients. There's a lot of information out there on managing average risk populations, but not for high risk. Having poor systems for capturing family history. We're not systematically collecting family history in electronic health systems currently. And having challenges in talking with family members who may not be their patients. So wanting to convey risk to family members but not having access to those family members. Some of the things that we really believe are not really known or we have inadequate evidence is how much of adherence among patients is simply due to the fact that patients don't know the guidelines. And how to communicate risk. Perceived risk comes up again and again as something that is a facilitator to screening, but we really don't know. There's not direct evidence out there to support that if we actually change risk that results in screening. We also see the need for effective interventions to test methods of communication within families. This was a recurring theme that although there's a lot of studies out there that have looked at communication of risk, genetic risk and screening in patients, families that undergo genetic testing, but there really aren't studies looking at those same types of questions in these high-risk families, again, not due to hereditary syndromes. And then lastly, of course, I think would all agree that collecting family history is a good thing, but surprisingly, we don't have the evidence in the literature that collecting family history will directly change outcomes. Will impact screening, one, and then impact patient outcomes. So in terms of interventions that have proven effective for improving screening rates, again, in these high-risk populations, we found very few. There were 8 randomized controlled trials. All of these had some similar components, but varied in their approach and their strategy. Some of the interventions were delivered by mail or phone, web-based, or in person. All of them were grounded in behavioral theory for changing behaviors, being screening. They varied somewhat in their study populations, but all were conducted in members of families. These are unaffected members of families with first-degree relatives that had colorectal cancer. And then they all varied in measuring outcomes in terms of follow-up time post-intervention. But all in all, the literature suggests that these targeted behavioral interventions can moderately increase screening adherence among first-degree relatives. The range of increase was from about 11% to 30%. The more intensive interventions, so those done in person and phone versus by mail, had a larger impact on screening adherence. In most of these studies, as I mentioned, the outcome was measured at one point in time, so it was either 3, 6, maybe 12 months post-intervention. What we don't know is if there's a long-lasting effect from these behavioral interventions. And we also don't know if these interventions would work if implemented into clinical or population-based settings, because these were all done in more research settings with very select populations that they were able to recruit either through population-based registries, family registries, or hospitals. But importantly, I think one of the limitations, even though our group would argue that we need to test these interventions more broadly, of course, to do that, we would have to have systems in place to identify these individuals with family history that would be eligible for target interventions, and again, either at a population-based level or within the healthcare systems. And so lastly, question 6 was what types of tools are available for assessing family history to inform screening. We decided for this question to take a convenient sample to give us more an idea of what the landscape is and what is out there. What we did find that there's several freestanding tools for collecting family history. They vary in their intended use, the data that's inputted into these systems or models, and the endpoints. These tools focus on family history collection or risk assessment, or some of them both. They do provide guidance on screening in addition to lifetime risk for colorectal cancer. And these tools there's both publicly available tools, and there's some private and commercial tools as well. And the suite of tools does seem to be growing. What we don't know, because these tools are relatively new, very few have been evaluated in terms of their reach, so who's using them, how are they using it, what is the utility, and the acceptability, both from the provider side and from the patient side as well. And then there's this remaining question out there of how to link these tools with electronic health records, if in fact that would sort of optimize their use in clinical practice. And as I alluded to earlier, of course, does collecting family history change clinical practice? I think we all think that it would and it should, but we don't really have that evidence to support that it actually does just yet. So based on these findings, the task group came up with 8 recommendations listed here. I suppose I'm going to hand the ball off to Dennis, who's going to go through some of these and discuss in a little bit more detail some of the work that the task force is doing or the roundtable is doing in this area, as opposed to me. I'm going to leave these on the screen for a moment for you to read them all, and then I'm going to pass the ball to you, Dennis.
Thanks, Jan. Yeah, that was really accomplished what the task group wanted to accomplish, and that was, what do we really know? How precise do we know the information about family risk? What kind of screening recommendations there are? So that's really a nice basis for then dealing with these recommendations. Can you pass the presenter thing to me, Jan?
Yeah, sorry, I'm still trying to get
and so I want to go through these recommendations sort of specifically and break them down into some of the things that the roundtable has made some effort to address. And the first 2 I'll take together. Establish a standardized core set of data items for collecting family history directly into EHRs or integrating those into EHRs from family history tools is one of the last items that Jan talked about. And the second is related, requiring collation and updates of family history as a quality metric in primary care. So actually, in parallel with this review, the task group and the roundtable had recognized that if we were going to do a better job of using family history, we needed to be sure on what we needed to do to collect family history in a standardized way, and needed to define, at least from our clinical end, what are the essential elements that are required in any high-quality family history, cancer family history section, and focusing on colon cancer for our purposes. And so the approach that we took to begin this was to develop a Delphi survey, an expert Delphi survey, asking these questions about components of the family history, the cancer family history, that we thought were important, that every EHR family history section should include. So we're about halfway through this process. The participants, all the participants took this Delphi survey. It was about 18 questions. There's 30 participants in this expert panel. Half of them are primary care providers, and then the others are split pretty evenly between genetic counselors and gastroenterologists and colorectal surgeons. The purpose of this exercise was try to develop an expert consensus about the minimal essential content that should be expected in the family history section of any high-quality electronic health record, whether that information is put in directly into the EHR or put in from a personal health record, what should be included. And the domains were 5. We asked questions about the goals of the section, what are the essential elements with respect to who should be included, and what types of cancer should be included. We asked questions about how it should be maintained, by whom and how often. And importantly, that what are the capacities that are required of an electronic health record to make use of family history information in clinical decision-making, and what, if any, incentives can be developed to try to encourage the development and use of high-quality, informative family history sections in EHRs. So this, I'll just give you a flavor of the kind of approach that we took. What's shown here are a series of questions related to the goals of the family history section of the EHR, and on the right is this graph that shows the percentage of individuals who either agreed with this question. Strongly agreed is in the light blue, agreed is in the purple, the yellow is neither agree or disagree, the blue is disagree, and then there's another one that doesn't appear on here that's strongly disagree. And so we asked these experts to give us their opinion about these various goals of the family history section. And I'll just show you one example, maybe the one that has only blue and purple, the third from the bottom. This asks the question, should like the family history section of the electronic health record be able to do these various things? And so to identify patients who are higher than average risk for colon, breast, endometrial, ovarian cancer, and who as a result should have more intense screening. All of the participants either strongly agreed or agreed with that. Similarly, there was strong agreement on whether that the electronic health record should be able to help a primary care provider identify individuals who should be referred for genetic counseling. There was very strong agreement on several of these goals, and I won't go through these in individual detail, but I will sort of summarize the points that we've already come to considerable consensus. Consensus is generally defined in this Delphi survey as greater than 80 or 85% agreement, and you can see there are many of these that have reached that where the purple bar is beyond the 80% range that is generally considered as consensus. Let me just go through some of the specific ones where I think we've reached consensus already. In respect to the goals, that the family history section should identify patients who should be referred for genetic counseling, are at higher risk for any cancer due to their family history, and as a result need more intensive screening, that meet criteria for hereditary cancer syndromes. With respect to the elements that are essential to be included, that in the past medical history of the patient's history themselves, a personal history of all cancers and colon polyps with an age of diagnosis was thought to be essential to be included. The essential elements in the family history, the consensus was that all first-degree relatives, second-degree relatives with cancer should be included with their ages, and including an option for age range if the exact age isn't known, that all cancer types that would change cancer screening should be, cancer screening recommendations should be included in every high-quality EHR. The data elements themselves and how they should be collected, strong consensus that they should be entered as discrete options in searchable fields and not as text options, that they should be importable from a family history tool or a patient portal, that they should be updated with when new information becomes available, but no consensus about what discrete time that meant. There was broad consensus that the family history section should have some capacity to help with medical decision making. They should be able to alert the provider that the patient is at elevated risk due to their family history or the possibility of a hereditary cancer, and or that they might need different screening on the basis of their family history. There's also a broad consensus that the EHR should be able to provide links to the provider about the current family history-based screening guidelines. And finally, there was really very strong consensus that the EHR needed to provide linkage of family history to medical decision making. And that linkage should be incorporated by the vendors and should be guided by national standards. Interestingly, there was no consensus that family history collection and updates of the family history should be included as a quality metric, particularly among the primary care experts on these panels. And that may well be because they feel overwhelmed with all the current quality metrics that are being requested of them. So anyway, I think we've made real progress here in coming to some consensus about what we think needs to be incorporated into every electronic health record. We hope to use this information both to publish it, but also to work with vendors to try to incorporate this more generally and with specific vendors to try to address issues related to that vendor and that EHR in these consensus elements. We go to the third recommendation, catalyze an effort to come to consensus on screening guidelines for individuals with a single first-degree relative over age 60. We showed you that that's the single group that has the highest variability in recommendations. And this is the same data that Jan showed you, but broken down by the individual organization on the left. Their definitions of this increased risk group vary. They vary on the basis of whether any adenoma or advanced adenoma. These are the things that Jan already commented on. So the definitions vary among these groups. The modalities recommended might be any acceptable modality, fit testing, or any of the 5 now accepted modalities by some organizations in colonoscopy. Others, there's variability in the starting age, either 40 or 50. There's variability in the interval. So substantial variability here. And there was a real consensus among the authors of this paper that this variability leads to confusion and may, in fact, lead to lower screening rates as a result of people not knowing what to do. And so I'm on the NCCN guideline committee. We just met on Tuesday and recognized that this is an issue, that differences in recommendations is a legitimate issue, and made some effort to try to consider harmonizing with other organizations when it's feasible. We're all looking at the same data, but are emphasizing different parts of the data. I think there's a real opportunity to work with each other to try to decrease some of this variability, and I think that would be worthwhile to accomplish. And I think there was a consensus that would be worth the effort at NCCN, and we'll move forward with that. I think one thing that we should all be able to agree on is that if we wait until age 50 to start talking to our patients or as individuals at risk, start talking with our providers, if we wait till age 50, we're going to miss the opportunity to start earlier in individuals that should start their screening before age 50. And so maybe we should focus on trying to change the narrative from start screening at age 50 to talk with your primary care professional by age 40 about colon cancer screening. That will help identify high-risk families and get them screening properly. But interestingly, it will also help this issue. If you look at in the average risk population at the screening compliance, screening rate as a function of age, you can see it increases with age, and particularly in this younger age group on the left, the 50 to 54 and 55 to 59 as well. The screening rates are substantially lower than they are in the older age group. If we were to start discussions about colon cancer screening at age 40, we would identify high-risk families, and we would also have an opportunity to get individuals to start on time, to start their screening at age 50 at recommendation, because some people will need several sort of approaches and reminders at this in order to start on time. So that would be another benefit of talking about colon cancer screening before age 50. Recommendation number 4, conduct additional studies to assess the risk associated with colon cancer, family history, and adenomas. I think this is an important area. The roundtable itself doesn't conduct studies, so we haven't addressed this directly, but we certainly have directed it indirectly in our responses to 5 and 6 here. So recommendation 5 was to educate primary care providers on appropriate application of guidelines for high-risk patients and to develop standard reporting metrics for disclosing endoscopy findings, specifically information about polyps and screening recommendations for high-risk individuals. This last one is a unique opportunity, I think, for gastroenterologists. Having a first-degree relative, having an advanced adenoma yourself is a risk factor for the future development of adenomas and cancer, but it's also a risk factor for your family members. And generally, the gastroenterologist knows whether somebody's had an advanced adenoma. The patient knows that they have polyps. They may not know the implications of being an advanced adenoma, other than that they were advised to come back earlier. Certainly, their first-degree relatives don't know that, and their first-degree relatives providers don't know that. So I think there's a real opportunity for that, and also to educate providers as well as specialists about how to identify these high-risk individuals in their family. Yesterday, I think, we were able to complete and have sent you all links to this brief. This is an addition, a supplement to the brief for gastroenterologists about how gastroenterologists can help this effort by identifying high-risk patients and their families in their practice. This is, you're the first group that's had an opportunity to look at this. If you have feedback for us, we would very much appreciate it. And we sent you links, and you can also get it through the roundtable website as shown here. I'll just give you an idea of the general approach. that we've taken and made 5 suggestions to help aid into the gastroenterologist do this. Those are to take a focused family history for every patient in their practice that will help identify high-risk families, to keep abreast of these colorectal cancer screening guidelines on the basis of family history, to establish a process that works and works efficiently for referral of high-risk families to a genetic counselor or a genetic specialist to make sure that they get appropriate counseling and testing when indicated, to use the endoscopy suite to identify high-risk families by doing molecular testing of tumors for microsatellite instability or to try to identify Lynch syndrome, to try to identify folks with advanced adenomas and make sure they know that that diagnosis has an implication not only for them but for their family members. And then finally to use and develop tools to provide screening recommendations to relatives of the patients that we see. I think these are practical steps that this family history brief is pretty user-friendly, provides links to sources to help with each and every one of these, and we hope it'll be useful. These last 2 recommendations are not ones that the roundtable has directly been addressed, but I know Jan has had a real interest in both of these actually, and so I'll ask her to maybe talk a little bit about maybe not what the roundtable is doing specifically, but what's going on in these areas.
Sure, thank you, Dennis. Yes, I wanted to share with you all a few things that are going on in the world of public health that relates to these 2 recommendations. Notably, the CDC has funded 5 states, including Colorado, Michigan, Oregon, Connecticut, and Utah, to develop statewide programs around cancer and genomics. And all 5 of these programs are housed within their state Department of Public Health. And as it relates to some of the recommendations, there's 3 things that these states are working on, and they tend to collaborate together. They're not working in silos, but across all the states working together on 3 fronts that I think are of interest and potential opportunities for the roundtable to become engaged in. And first of all, they're all working with the public health cancer screening programs, so both for colorectal cancer, but also for the breast and cervical cancer screening programs that are available in all of these states, and in fact, most states across the United States. And they're working with them to integrate collection of family history into their programs, so that now they're not just offering screening, but they're able to offer risk-based screening to these populations that utilize those programs. They're also working to improve data collection around family history for these programs in the hopes of making this a standard practice, that the data that are collected locally are then transferred nationally, so we would have access to that information at a national level. The second thing that these states are doing is incorporating questions about family history into their population-based surveys, so their behavioral risk factor surveillance surveys that they all implement, collecting information about family history, screening, and also some questions about genetic counseling and testing as well. And the third thing that these groups are working on is whether they can, to what extent they can use the cancer registries within their states to do outreach directly to patients. And we've done some of that work here in Colorado, where we've identified individuals at higher risk for colorectal cancer, identified those survivor groups, and implemented direct outreach to these patients in hopes that they would pass that information along to their family members. So again, these are just some things that are going on in the world of public health that I think would be of interest and potential partners for the roundtable as well.
Thanks, Jan. We would really like to thank the people who did much of this work, other members of the Family History Working Group. We sponsored a symposium to address some of these issues and set the groundwork for what the questions we wanted to ask in this family history table were in this family history paper, and particularly the Roundtable American Cancer Society and the CDC for helping put on this webinar. And now I will turn it over to Paul to help us with some of the questions.
Well, thank you, Dennis and Jan. That was terrific. Now we'd like to take some time for questions. We have until the top of the hour, so we will try to get through as many as possible. If you do have a question, please submit it in the chat box and we'll take them one by one. So the first question that was raised related to this issue about communicating findings from a patient to a physician, or back from the doctor to a patient or a patient's first-degree relative. So the question is, how does one convey this information? But more importantly, the person who raised the question acknowledged that number 6 on our recommendations sort of talks about developing standardized metrics for this kind of reporting. But in the short term, Dennis, what do you do when you're taking a family history and they simply acknowledge that their patient had something and perhaps it was a polyp? How do you act on that kind of information?
Yeah, this is part of the real problem of communication of polyps. There are 2 ways. One, you're seeing a patient that says, oh yeah, my brother had polyps, or some other close relative had polyps. I think it's very important to recognize that it's not all polyps that convey an increased risk. We know more about adenomas than the family history of other kinds of polyps, like serrated polyps, for example. So it really focuses on adenomas and advanced adenomas. About 30 to 50% of the population in the colon cancer screening age have adenomas. As we get better at identifying adenomas, a bigger and bigger proportion of the population have adenomas. It doesn't pass the last test to consider that all of their first-degree relatives are in high-risk group, because that would be the entire population. So really, to me, it makes very good sense to limit this concern about the family history of adenomas to those with advanced adenomas. That's adenomas bigger than a centimeter, adenomas with high-grade dysplasia, or those that have villus or tubulovillus architecture. It's a small group, to maybe 10% of all adenomas are advanced adenomas. In that group, I think it's important information. But we have a responsibility as gastroenterologists to make sure that the patient knows that information, to do a much better job of providing information about what that means for them and what it means for their relatives. When a patient comes to you, you can ask those questions about their relatives. Well, how often, were they asked to come back? People with advanced adenomas are asked to come back in 3 years. So if they say, oh yeah, they told them to come back in 10 years or 5 years, you can be fairly comfortable that it wasn't an advanced adenoma. But this is a real difficult issue. But I think it has to start from the other end. It has to start from the gastroenterologist providing in a systematic way information about whether the patient had an advanced adenoma and then what it means to their relatives, and provide them an easy way to get that information to their relatives. So that's the approach that I think would work.
Okay, thank you. Jan, one of the questions related to what are the publicly available tools and where might one find these tools?
So 2 that we looked at and included in the review are My Family Health Portrait, which is a product from the Surgeon General, and the second is My Family Healthware, and that is from the CDC. And both of those should be accessible online.
There's also a group called the Fed Non-Fed Family History Group that's put together a resource list. And I don't have the link to it right handy, but I think we could get that and send it out to the folks that are on the webinar. And there are a bunch of them that have different kinds of strengths and weaknesses, but at least it's a resource you could start to see what kind of tools are out there.
Okay, thank you. There's a whole host of these questions that have flown in here. Perhaps, Dennis, you could address this next question that appeared. Since high-risk patients are encouraged to undergo screening colonoscopy, the current FDA-approved blood-based colorectal screening test, have there been any, or this relates to the stool-based test, have there been any studies evaluating this screening test in high-risk patients?
The stool test in high-risk?
No, this is the blood-based screening test.
So Septin9 that has been recently approved by the FDA as a screening option. It was not included in the U.S. Preventive Services Task Force recommendation, and so it's not therefore automatically covered with no copays in the Affordable Care Act. We have very limited information so far about blood tests. This is obviously the holy grail. If we could identify a reliable blood test for colon cancer, that would be a real advantage for groups that would prefer a blood test to any of these other options. The second would be if we had a blood test that really could identify advanced adenomas for thyroid, that would be like the second level of, that would be holy grail on steroids. But the SEPT9 does not do that. It's pretty good for identifying cancer, but not very good for identifying advanced adenomas. I think there are big companies now that are working in this area that are putting big money into trying to do a better job of identifying blood tests. And I think there may be a future here. I think we may be changing recommendations over time, but I don't think we're there yet. And they haven't been tested in high-risk groups, as best I know.
Okay, thank you. Jan, can you speak to the risk and recommendations for patients with 2 or more second-degree relatives with colon cancer?
2 or more second-degree relatives. Now you're going to test my memory on that. Very few of the guidelines include second-degree relatives. I don't know, Dennis, if you know offhand what the risk is associated with those. It's less than 2. It's somewhere between maybe 1 and 1.5 would be the risk of second-degree relatives. There have been studies out there that have taken the approach of looking at various combinations of family histories, which might include a second-degree relative, even a third-degree relative. But I think the strength of the associations are much stronger for having first-degree relatives. But nonetheless, there are some guidelines that suggest that screening should be a little bit more frequent among persons with a second-degree relative as well. Dennis, you might want to add to that.
Sure. I think that only the NCCN guidelines are quite specific about second-degree relatives, and they used to include, as you said, second-degree and third-degree relatives. There are several problems with the second-degree relatives. The recommendations are complex enough as they are. We're not doing them, so we worry about making them too complex and then defeating the purpose of the guidelines at all and getting screening done. The second is that we have reliable data to suggest that people know the cancer history in their first-degree relatives. But when you get to second and third-degree relatives, the reliability of that information is substantially less. So that's a problem that would have to be addressed by getting information and verifying it by the patient typically beforehand. So it makes it a little more complicated to get the family history, and therefore would have to do it before the patient came in for a visit, for example. So anyway, I think the relative risk of a second-degree relative is certainly less than a first-degree relative. Age is important in that second-degree relative, and it's about 1/2 to 3/4 of the risk of having a first-degree relative. And the number is somewhat, it's not additive, but it does increase with having 2 second-degree relatives as opposed to 1. I don't think any of them honestly get to the relative risk of 2, which a lot of people consider the threshold for changing screening recommendations.
Okay, so this lends itself to some of the complexities with this risk communication piece, particularly with regarding pulse. But the question is, what is considered an advanced adenoma? And secondly, are there any studies on immunochemical fecal occult blood testing for patients with a family history of colon cancer?
So the fecal occult blood testing, was it the fecal occult blood testing or the still DNA fecal occult blood?
No, this was, the first question relates to what is an advanced adenoma, and the second was, are there any studies on the effectiveness or efficacy of immunochemical stool blood testing for patients with a family history?
Yeah, so the first question is, what's an advanced adenoma? An advanced adenoma is defined as one that's larger than a centimeter in size, so larger than thigh. One that is has under the microscope, the pathologist identifies high-grade dysplasia or identifies that the polyp has villus features or is tubulovillus under the microscope. So 2 of them are pathology, and 1 of them is size of the polyp. That's an advanced adenoma. There are studies that have been proposed to use fecal immunochemical testing, high-sensitivity fecal occult blood testing for in high-risk groups, but none of the recommendations include that, and I haven't seen the data about how effective it is. The worry is that in some of these high-risk groups, the risk is so high that you really want to use a test that will help you identify not only early cancers, but precursors to those cancers and polyps. And none of the stool blood tests do as good a job as imaging tests for identifying advanced polyps of the colon.
So unfortunately, we're at the top of the hour, and we didn't get to answer all the questions that were submitted, but we will answer them by email, so stay tuned. So in closing, I'd like to share a huge thank you to Dr. Anna and Dr. Lowry for their outstanding presentations, to the Family History and Early Onset Colorectal Cancer Task Group for their work on the review, and to the CDC for providing the funding to make this webinar possible. We'll hope you'll join us for the Roundtable's next webinar on January 10th, in which we'll preview the new How to Pay for Screening Navigation Toolkit. For more information on today's webinar, please email our the following address, nccrt@cancer.org. We'll also send a follow-up email to all of you with some of the resources we've mentioned. So thank you kindly for joining us today, and I hope you all have a wonderful afternoon.